So today's speakers bring complementary clinical and lived experience to advancing family-centered care in neonatal neurocritical care. Dr. Alexa Craig is a neonatal neurocritical care physician at MaineHealth and clinical researcher. Betsy Pilon is the founder of Hope for HIE, which is a parent of a child with HIE. Dr. Elizabeth Sewell is a neonatologist at Emory University, and together they have led an international advocacy effort to advance parental holding during therapeutic hypothermia in partnership with the Newborn Brain Society for the Polar Bear Care HIE Hold-a-thon. For those of you who are unfamiliar, HIE stands for hypoxic ischemic encephalopathy, and I will let these ladies take it away and share more about what they're doing to support family-centered care practices in therapeutic hypothermia.
Awesome. Thanks so much, Morgan. Betsy and I have been putting our slides together with Liz, who's also on service, so she's been manic busy lately. So we're gonna do this on the fly, where we're gonna give the talk, and we're also gonna work out who's giving what, who's speaking with with which slides at which time as we're doing it in real time. Okay. So bear with us. I'm gonna share the slides and I'll run them if that's okay with everybody. I'm hoping this will go into presenter mode here. How does that look? Does that look good? Thumbs up, everybody. Awesome. So as you said, Morgan, the title of our talk is From Feasibility to Global Movement, Parental Holding as a Model of Family-Centered Care During Therapeutic Hypothermia. And just as a real quick sidebar, I know we're supposed to keep this to about 20 minutes, but it's impossible to talk for just 20 minutes when you get to work with such a phenomenal team. And we have many more behind Betsy, Liz, and I who have been contributing to this work. And it's just been truly a dream come true for me to have moved this forward at the pace that it's moved forward. I'm awestruck and speechless. I'm not going to spend a lot of time, but here are disclosures for different grant funding sources of support for work we're doing, and collaboration with both Newborn Brain Society and Hope for HIE. It's important to, sort of call out that these are two equal partners in this work. The objectives for our talk are to describe the psychosocial rationale for parental holding during hypothermia, talk about trauma-informed care for infants with HIE, summarize the existing feasibility and safety literature on holding, and then discuss this international, really exciting polar bear care hold-a-thon during HIE thing that we've been doing, this big advocacy project. So just the other day, I didn't know this was going to be done, but you guys did this really neat survey. And so you sent it to us, and I scrambled and I incorporated it and reordered all the slides, which is, I think, why we're going to have this shuffle of who's speaking when. But I just wanted to respond to it because it's so wonderful to have like people's own perspectives and trying to design the talk to respond to that. So here goes. So one of the questions that you might have been one of the people who responded to, because it looks like we had about, I can't do math that fast, but 48 responses or so. Does your NICU encourage families of infants with HIE to hold during cooling? And it looks like about 35% of those who responded said yes to that. And then if yes, does your unit use a formal policy or guideline to ensure safe holding during cooling? And about 46% or so, about half of people said they are doing this in a guideline-driven way. And what I wanted to point out is that you're right on par with what's going on nationally. So I think that this only 38% is the thing that we were responding to as people who have been pioneering this work, is how can it be after, kind of 8 years after the first studies were published, only a third of people have picked up on this. But this is a neat study that people can look at, where they did a big survey of all different ways in which care was provided to babies who are treated with therapeutic hypothermia. And it's international, from high-income places, the US, Canada, and Western Europe, but broadly represented 105 sites. So what I did with all the people from your organization sent a lot of really wonderful comments along with those survey questions. And so I did a real quick sort of a qualitative analysis and bucketed them into 5 buckets. And so the 5 buckets of things that are challenges for people, challenges that people face when they want to do holding during hypothermia. We're going to talk about each of these buckets one at a time. So the first bucket is kind of like safety concerns, like the newborn's clinical status. The next one is knowledge, experience, and training gaps. The next one's equipment, technology, and logistics, culture and provider mindset, and protocols, policy, and standardization. And the hope was that as we talked through each of these buckets, we could sort of think about ways to overcome these barriers. So this is bolded because we're going to do the newborn clinical status and safety first. And I pulled out one of the quotes that you sent along that said, our policy states that cooling patients will have a UAC line that prevents them from being held while the line is in place and maintaining low temperature. So I want to dispel that myth, okay? So one of the biggest studies that's been done was published by David Odd and a colleague that I know from Bristol in the UK, Ela Chakrapani. And what they did was a prospective observational study in the United Kingdom of 2 NICUs. And they allowed parents to hold babies from October 2019 to November of 2020. And 70 babies were held during this time over a cumulative duration of 115 hours, 18 of which were done during rewarming. And they monitored their vital signs like crazy. So they looked at their core and their surface temperatures. They looked at their cardiorespiratory and neurophysiological data. And it was measured every 5 minutes for an hour before they call holding in the UK cuddling. So an hour before the cuddle and then post cuddle for up to 2 hours. And this is a super busy slide that I lifted right from the paper. But here you can see the rectal temperature of the baby. The mean is staying right at 33.5. Obviously, you have some kids going up to 33.8 and some kids going down to 33.3. But what's important to see is if you look at all of those lines, they sort of go up and then the blanket does its job and brings the kid back to the right temperature. And this is not in excess of the up and down in temperatures that happen just in routine provision of therapeutic hypothermia. He looked at mean airway pressure, end tidal CO2. Over here were heart rates. Over here was mean arterial blood pressure. And over here was regional cerebral oxygen saturations. And there's really no change in the pre-cuddle area here in white, the cuddling time here in purple, and then the post-cuddling time. So I think that this can tell us that there's no clinically significant vital sign changes when babies are held during therapeutic hypothermia. Another study that was more recently done was done in France in 2025. This study looked at 58 newborns, and these babies, like the other study, were also intubated, but none of them were on an oscillator. Their median hold time was 83 minutes with a standard deviation of 26 minutes. 6 of those babies were held in the first 24 hours, 16 between 24 and 48, and 8 between 48 and 72 hours. And this study noted that it takes 2.6 nurses to move the baby from the incubator to the parent's arms. So I think that probably rounds up to 3 people. I don't know how we do it with 2.6. That's a funny mathematical number there. When we looked at the metrics associated with holding, what we see here is that this is our goal temperature of 33.5. And if we look at the 5 minutes prior to holding, you can see some babies are as high as 34.1 before they're even held. 5 minutes after holding, the blanket is bringing them in. 30 to 60 minutes after the start of holding, we have a nice tight, except for one baby at 34.1, a nice tight, kind of bar right around 33.5 at the end of holding, and then 5 minutes after holding. So it's rarely, very tightly regulated. The cooling equipment does the work. And then this bar graph over here is showing that the parents, which are the white bars, and the nurses, who are the gray bars, are feeling really positive about holding. So 9.5 out of 10 for does cooling benefit the baby. The parents feel reassured by cooling, almost a 10 out of 10, very low apprehension scores and very low discomfort scores for the parents. And then similarly for the nurses who are actually making this happen, a 9 out of 10 score for satisfaction of doing this work, and then low apprehension and low increased workload. And I think this is really important, this 3 here, because it takes 3 people to move the baby, and still it's such a positive experience that it's being scored as not a really significant increase in workload. So I was going to let who wants to do this next one? Knowledge, experience, and training gaps. Either Betsy or Liz. You guys get to call it.
Rock, paper, scissors, Liz.
Go. Great.
Okay. Want to go to the next slide?
Yeah.
So, oh, sorry, I see the quote. see, we really are ad-libbing on the fly here.
Sorry,
So
guys.
we'll talk about knowledge, experience, and training gaps. And one of the quotes that we got from this community was that team members don't have enough experience in doing that and are concerned for the infant. And so I think that brings an important point that we have to give people the knowledge and the education and the training to empower them, to do this and to make a difference. And so when we have a baby with HIE, this is a really traumatic event for the family. They came in expecting no complications. They may have had a birth plan. Most of the time these babies are born at term, and there really often is no warning. And so to have this idea of how your delivery and your birth is going to go, and then to have that taken away, potentially not even be able to see your baby, potentially not hear the baby cry, that is really traumatic and has profound effects on the parents, not just during their NICU stay, but for years afterwards. And so that is kind of where we are starting from, right, with the baby in the NICU. And so Alexa has published a previous article. Alexa, if you don't know, has done a lot of work, and a lot of her research centers around holding during hypothermia. And they really found three main themes: the feeling of trauma, the loss of normalcy, and the separation. And there's one quote that they lifted from the paper, where there's no baby crying. So I just said to my husband, I don't hear him crying. And he's watching the chest compressions, which is an image he says he cannot get out of his mind. And so I think that's really powerful. And I think it's important to remember, when we are dealing with some very important medical therapies that need to happen, but just to keep in mind where the parents are at, and kind of this dramatic shift from expectations to the reality of what's happening. And so there's a lot of work to think about how to communicate in a trauma-informed way. And I think that can speak to a lot of different areas in the NICU, but particularly with HIE. And so there are 6 guiding principles that we think about for trauma-informed care: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and cultural, historical, and gender issues. And so this, I think the previous work has been amazing and really started looking at some of the evidence behind holding during hypothermia. But one thing that I think Alexa has really brought to everybody's attention is that we really need to be doing this through a trauma-informed lens. And so most people on this call are probably familiar with skin-to-skin care or kangaroo care. And it's when we really have a newborn that is really naked except for the diaper, where it's held against a parent's bare chest. And we talk about this a lot, in preterm babies. And there have been some dramatic benefits for both the newborn and the parents. So for newborns, it's been shown to reduce mortality, to stabilize vital signs, including the heart rate, breathing, and temperature, aids in establishing feeding and breast milk supply, and promotes overall growth and development. And for the parents, it can stimulate oxytocin, so therefore will directly help with breast milk production. It fosters bonding and attachment, and reduces parent depression, anxiety, and stress. One of the concerns with HIE, of course, is concern about temperature dysregulation if we do direct skin-to-skin care. And so the next question is, can you see some of these same benefits with holding that is not directly skin-to-skin? And there are times, I think HIE is the big one that we're talking about today, but there are other times as well where you may not be able to do direct skin-to-skin care. And what we found in summary is that some of the same benefits are still seen with holding, even if there's not direct skin-to-skin care. And so we can skip to the next slide. Really, a lot of these benefits come from oxytocin release from the mom. And so that's really driven by tactile and kinesthetic stimulation that can happen regardless of whether or not the infant is skin to skin. So we still see some of these benefits with holding. Okay.
Betsy, I think you're up. You want to do equipment, technology, and logistic complexity?
Sure. All right. So we've heard a lot of feedback over the past, I'd say, several months in many different forms of what challenges that people face that prevents holding during cooling. And some of the things that have come up are newborn, clinical status and safety concerns, obviously, dislodgement of, anything from the umbilical lines to, ventilators and other things. Knowledge, experience, and training gaps, obviously the equipment, technology, and logistical complexity. And so when we go into implementing this as usual care, this is again from the UK group. Really goes over a lot of the what they learned in this implementation. And so there's lots of great resources out there. This is one that comes from the Cool Cuddle team of, what it's like. So to prep parents, what to expect as they work to hold their babies. And again, for staff, there's so many training videos. This one comes from Cool Cuddle. There's lots of other videos that are available that we've put together for this hold-a-thon as well, that are both in this graphic format and live, showing the babies during the move with the staff into the parents' arms.
Okay, you want me to take over and do culture and provider mindset?
Sure.
The links to all those videos are on the last slides if people are interested for those to actually watch them. We just didn't want to take too much time to watch them. So sorry, the quote here is neonatology buy-in holding during rewarming has happened. That's pretty late, but it's better than no holding. And then the other quote was comfort of providers and staff. That seems to be a barrier. I really felt like familiar with the barriers because this is the first study that I published about this topic where I had to navigate and negotiate with the neonatologists in my NICU who were absolutely terrified and thought this idea of holding during hypothermia was bananas crazy. And so what we did was we actually got we whittled it down to inclusion criteria, and we didn't hold anybody who was intubated. We didn't hold anybody who was seizing. We had all of these inclusion exclusion criteria. And then we sort of settled on a 30-minute amount of time. And we took vital signs every 2 minutes during the 30 minutes that baby was in the arms of their parent. And we took the vital signs before and after. And I put this picture of this styrofoam barrier here because we actually bought the material that you put between plates when you're packing, to move your house. And that's what we put a layer of between the parent and in the cooling blanket. More now we recognize for the parent comfort because the cooling blanket obviously does the job and keeps the vital signs stable. So I think that I put this picture, and unfortunately I felt like I needed to blur the faces, but there's like tears and giant smiles on the mom and the dad in this picture. But this is the first parents that ever held a baby during cooling in our unit. And I think that we can talk about like hearts and minds changing and like talk about statistics and safety and vital sign parameters. At the end of the day, if you can get a child into their parents' arms and you can get as many members of your clinical staff to witness the joy of that moment, that is the thing that makes people understand how important this is. And so that's why I put this picture here, also partly to show how we do it. It's not showing how the transfer happens, but it's showing a parent sitting in a comfortable recliner with some pillows and the packing foam behind her. And then we didn't do such a great job to have a place for the dad to sit, so he was sort of squeezing into the photo. In terms of kind of this like idea of overcoming these mental barriers, and change is hard for anybody. But in this original study, we asked the mothers were the parent that we allowed to hold because we were thinking about the oxytocin and increasing breast milk supply, and then hopefully decreasing length of stay because feeding would happen faster. So we had limited it to moms.
I love you. Very good. I'll see you shortly.
Uh-oh. So anyway, parents there were only 10 mothers in this survey, but they said that before they held their baby, it was very hard to bond with their baby. And after holding their baby, 100% of them felt like their bond was stronger. Before holding, their stress level was either high or very high for 90%. And after holding, 100% felt less stressed. And 100% were glad they had the opportunity to hold their babies and also thought that other parents would benefit from this opportunity. We also surveyed the nurses because we wanted to have like a full 360 view of what it was like for everybody involved. So before holding, 2 out of the 8 nurses who participated were really nervous about holding, but 8 out of 8 agreed that holding during hypothermia was safe. And I love qualitative research, which is why I throw in so many quotes, but I think this one is particularly poignant where the nurse says, being a part of this emotional experience made me feel closer and more connected to this family and gave me a different perspective on just what they had been dealing with, the they being the parents, and feeling since giving birth to their child, which every time I read that always gives me goosebumps. The other thing is that more than half of the nurses commented that the baby appeared more relaxed, more calm, and less irritable while it was being held, and that the nurses could see the bonding happening. And all of the nurses agreed that it should be standard practice. That led us to do the next study in our NICU, which was a prospective crossover study where we again let moms hold their babies for 30 minutes and we checked the vital signs at the 2-minute intervals like we had done before. There were no changes for this cohort either. What we also did was we collected saliva and measured cortisol levels as a marker of stress. And what we saw on the day 2, so babies were randomized to either be held on day 2 or held on day 3. And the other day, we went through sort of a sham no hold where the parent sat next to the baby for half an hour and we collected the saliva before and after. So the biggest difference is on day 2, the mom's cortisols are much lower when they hold their baby as opposed to not holding their baby. And they're definitely lower on day 3 when they hold their baby, but the drop is not as significant. And the baby seems to follow that same pattern. The babies that are held have lower cortisol on day 2 and day 3 compared to the no holding part of this. So that's these are thoughts about how to change culture and provider mindset. It's really to get people in the room when this is happening, to win hearts and minds. And then there's a biochemical reaction happening. We are lowering stress for both parts of, for both the baby and the parent. So who wants to take the protocols, policy, and standardization section? Liz, you want to, or you want me to keep going? I'm happy.
I'll go. I'll go. Okay.
Right.
So, I can't read all the quote, Alexa. You may have to read the quote.
Okay, I'll read the quote for you. I would love to see a policy or the logistics for maintaining EEG leads in the cooling blanket. And then the other quote is, not sure if we have a policy stating that they must be in the isolette.
And so, there is over the last couple of years more publications and more evidence that is being published, that exists out there, talking about holding during hypothermia. And so, I think the question is this emerging as a standard of care? Even the Newborn Brain Society several years ago put out a practice care bundle looking at all the different systems for babies with neonatal encephalopathy. And they had a specific section that called out parents should be encouraged to be present at the bedside and participate in the care of their neonate. Holding their baby during hypothermia can be done safely, promotes bonding, may reduce discomfort, and may help parents cope with the stress of having a child in the neonatal intensive care unit. So, we have had several years where we are, trying to call this out as an emerging kind of standard of care. But there are still barriers and solutions that we keep hearing about through both NBS and Hope for HIE. So there are institutional barriers, such as lack of nationally endorsed guidelines and physical space constraints. And for each of these barriers, we've tried then to talk about potential solutions. So develop local protocols and collect data and adapt your equipment and spaces. So this can be done in private rooms or open bay NICUs. There are clinical, barriers for individual clinicians, perception of risk benefit. And so for that, we really think about staff education on the data that's been published and then staffing requirements. So do people have enough, Alexa mentioned earlier, they have 3 staff members when we move a baby getting cooled into a parent's arms. So having flexible staffing protocols or minimal staff requirements that are needed to do this. And then if you don't have a protocol, then I think that puts more pressure on the bedside staff as well. So I think, having a protocol and doing simulations and hands-on practice. And then there are barriers for parents. So, this is a time of stress, trauma, and fear. And so trying to make sure that we are communicating with them in a trauma-informed way, making sure that we have peer support services available, and just letting them get educated a little bit about what the potential benefits are. And then, of course, competing obligations. And that's where we really rely on the entire multidisciplinary team to really make sure that we are supporting the parents. You want me to keep going, or somebody else wants to take it? Okay. So this is where we talk about how we came up with the HIE Hold-a-thon. And so, NBS has been around for several years now, and I think there has been so much progress made with education, with weekly webinars, with publications and guidelines. There's an annual conference. And so there has been so much good happening. And several of us were just talking one day and realized what was missing was advocacy. And we are so fortunate to have a close relationship with Betsy and Hope for HIE. And so what we decided would be the inaugural advocacy project for NBS would be holding during hypothermia. So this was a project that was started last year, and we have really tried to make this we've done specialized education and webinars. We are working on publications, and then we have started the Hold-a-thon. So our vision for the HIE Hold-a-thon is a future in which care for newborns treated with therapeutic hypothermia includes safe, trauma-informed opportunities for holding that supports newborns and their families and that fosters bonding. And the mission is to advocate and educate about safe and trauma-informed, family-centered care practices for holding newborns during treatment with therapeutic hypothermia. And so we envision the Hold-a-thon as a structured unit-wide initiative to develop, designed to promote and normalize holding by providing standardized clinical support, staff engagement, and cultural reinforcement and family-centered care. So this was, of course, a play on kangaroo-a-thons, which have existed for a while in preterm babies, and really to bring the focus to a population in term infants that also spend a significant amount of time in our NICU. And so this, I should let Alexa say this, but this is actually, the logo is designed by Alexa's fabulous daughter, and we all fell in love with it immediately. So we really have designated polar bear care to not only play off kangaroo care in preterm infants, but to also kind of recognize that we should be doing this in a trauma-informed manner and making sure that that is a priority.
And I think what I want to chime in and say too is that polar bear care is inclusive of holding and other types of therapeutic touch and intervention, where, if holding is not feasible, there's other developmental care and trauma-informed care that families can participate in, hand hugs and things like that, that I think the preemie population is very aware of. But as a parent to a child who is now turning 14 this month, which is wild, we were told, you didn't want to look at your child sideways because they were, the fear was instilled in us that we were going to harm our child by any form of touch, any form of stimulation, or, we could talk in very, very low voices in only a little bit of time to do that. And that was 14 years ago. Obviously, we know so much more now. Family-centered care, this task force has changed so much for improving cares, but that's the reality that so many of us parents felt because they just didn't know enough. Like cooling in 2012 was kind of becoming standard of care at that time. Now it is standard of care and has, been implemented so much. So I think, the different ways that families can get involved in their own experience is the whole premise behind polar bear care, kangaroo care, and all of the work that's being done in this task force.
Betsy, I think you should just finish up. You're doing such a wonderful job.
Great. Thanks. So again, it's not, this is really about supporting NICUs. It's really empowering the NICU staff and the families to see what's possible and early on as well. It's not to mandate this care, and also obviously always to provide resources. So I mentioned it in the chat before, but we have created an easy URL that re-loops to a landing page on the Newborn Brain Society website, but polarbearcare.org. So it's easy to remember, easy to go to. There's protocol templates, sample protocols, transfer checklists, video, like tons of video resources from the nursing perspective, from the physician perspective, from the parent perspective. There's parent resources, communication scripts, all sorts of things. And that will be an evergreen resource that will just get added to after this. We hope that this will be an annual event and initiative during April, which is HIA Awareness Month. But we hope that this will become more standard practice and a key part of family-centered care in the NICU for HIE families moving forward.
I had thrown this slide in just so people could see what the website looked like and to see the, see the where you would go. And we can, I don't know if it's worth, people can tell us maybe after when we're discussing if we want to go to the website and sort of look around and show people what's there. But yeah, I think that's, there's one more slide actually. This is the last one, Betsy. This is you.
Yeah, so this, we try to highlight different family experiences. And obviously, this year's theme for Awareness Month is Hold On to Hope, really talking about the holding campaign. And this was one of our family's quotes that we wanted to share. I have hope that families will get to bond with their babies sooner after birth. I didn't hold my daughter for 4 days, and it traumatized me in ways I'm still working through. With more family-centered care, I'm hopeful that the traumatic experience of an HIA diagnosis will be made more bearable and less daunting by implementing bonding sooner. So, and that comes from Jasmine, who's one of our parents. And you can see, I'm thrilled to see in the comments too, we have so many HIE parents that are joining us and chiming in about their experiences as well.
So these are all the papers that we cited, and then really some useful websites too. So I think, Morgan, shall I stop sharing and then we'll do the questions? Is that where you want to go next?